This is the Timmy Global Health chapter speaker series that's been happening this semester. Timmy Global Health, for people that are unfamiliar with what the organization is a local nonprofit here in Indianapolis that works in Ecuador, Guatemala, the Dominican Republic, and El Salvador, and does monthly or bi-monthly medical mission trips to communities there in the developing world. Our chapter here, we're doing a lot of fundraising efforts, but advocacy to kind of spread the word of the work that Timmy Global Health is doing, and we will have a community partner in one of those sites. More than likely, it's going to be the Dominican Republic. We're still trying to kind of get everything established here and get our feet off the ground as a chapter. But the purpose of these speaker events that we've been having every month this semester is an opportunity to hear from local leaders and leaders in global health to better our understanding of global health issues, and specifically issues around underserved patient populations locally and globally. And so tonight we're fortunate to have Mr. Bryan Mills, the CEO of Community Health Network. And want to thank everyone for coming out again. Also want to thank Dr. David Williams, familiar face to many of us, lecturer, but from Community Westview, thank you for coming. But we'll get to Bryan Mills this evening. Thank you.
Thanks, Zach. I hope this is an interactive conversation. Now, you will see no slides. I don't do slides. I don't like slides. I'd much rather talk about what's really on your mind and what really we're doing, and hopefully make this something that's worthwhile for you. But just a little bit of background on me. I'll tell a little bit more in a minute. But I'm, as Zach said, I'm the person responsible for the Community Health Network. I've been in community for just over 29 years, and the last 5 as the CEO out there. So that's why I'm here tonight, and I'll tell you more about our organization and what we do and where we are. But I really wanted to start out by just thanking you. I assume everybody here is in Marian University College of Osteopathic Medicine. No? Oh, nursing. Oh, that's even better. Thank you. Well, thank you. I'm going to get to that too, so that's wonderful. But my point about those that are in the School of Osteopathic Medicine is that, I know it's got to be hard, and I know that you're fulfilling a dream, and I know it's something you've pursued for quite some time. Not everybody can get in, but I want to thank you for being here at Marian, and being here in Indiana, and being a part of something that's new and innovative. That takes guts. That takes risk. This is something that's special. You're part of an original class, an inaugural class, and that's really tells me a lot about you. That you not only want to be a physician, but you're willing to take some risk. You're willing to do what you need to do, whether that's for your patient or for your community or for your coworker. So I thank you for doing that. Now, you've decided that you're going to go into medicine. And you've done that at kind of a precarious time. I don't know that it's always been overly predictable, but definitely a precarious time with all the changes in the world, and we're going to talk about a few of those this evening. My background in the medicine is not a linear path. I thought hospitals were places you avoided. I did not know that anybody would actually volunteer to go work there. I don't like blood. I don't like sick people. I don't like injuries. When my kids get hurt, I hope somebody else can outrun me to get to where they are. But I'm an accountant. I went to school to become an accountant, and my plans were very simple. I was going to become an accountant, go to work in what then was a large accounting firm, try to get a job in a large accounting firm, get them to pay for my law school, go to law school, focus on taxes, which would be the most boring thing I could have ever imagined. I cannot believe I actually wanted to do that. Focus on taxes and estate planning and all this stuff related to regulation. Well, the only consistency between what I do now and that is regulation, because we got a boatload of regulation. But I completed part of that plan. The part of the plan was I became an accountant. I became a CPA. I went to work for a large accounting firm, but I never did a tax. I never did a tax return. I never went to law school. I didn't apply, but I did not take my offers. Because what happened is along the way, in 1982, somebody walked into, I worked at a high-rise building downtown Indianapolis, and I'm scared of heights. And so, anybody else scared of heights? No, just me, you. I did not know that when you got these tall buildings, they move. So I'm sitting there on the 34th floor of a building, and I can feel this thing swaying. I'm looking at everybody else saying, "Hey, does anybody feel that?" And they're like, where are you from? Of course they sway. That's how they're architecturally designed. Well, it wasn't a couple hours later, some guy walks in and said, "I need somebody to be a Grunch staff on a healthcare job. Anybody interested?" My hand went up and I said, "Is it on the ground?" And he said, "Why?" And I said, "Yeah, you're going to get in the car and you're going to drive." I said, "That's fine, I'm in." Well, I had the pleasure, they sent me to Gary, Indiana. Anybody from the region, Northwest Indiana? Gary, Indiana, northwest part of the state. And they told me to drive my car up there. When I got to 8094 and headed towards Chicago, when I see Grand Street, go north on Grand Street, no matter what you do not get out of your car. Get in your car, you have a flat tire, ride it to the parking lot and tell you a true story. I said, okay, so I go up there, and over the course of the next 3 years, I spent almost half my time in Gary, Indiana. And part of the story I'm proud of, part I'm not proud of, but the part that I'm proud of is that I had a calling of sorts there at Grand Street, because I realized what was so cool was that a group of people put other people first every single day. What I saw was that people took their issues, their problems, and they put that second, and they had primary responsibility for a patient. And I spent so much time up there. I spent a lot of time in the hospital, walking around, making friends, meeting people, trying to figure out what they did. And this whole idea of providing care was something that was really cool to me. Now, I'm still an accountant. I'm still not capable of doing anything clinically, but I thought it was special. Well, about that time, similar to right now, all the healthcare laws changed. And so they went to these DRGs, which you may have heard about, or prospective payment, or all this other stuff. That all happens in 1983. And so I decided that I'm going to be an expert in healthcare. And I'm going to focus my accounting career entirely on healthcare, and that's what I did. And then along came early 1985, my boss took a job at Community Hospital. And anybody from Indianapolis may or may not know that until 1985, Community Hospital, or the Community Health Network, was one hospital. And that hospital is at 16th and Ritter on the east side of Indianapolis. That's all there was. And they were going to build a new hospital in the middle of nowhere called Community North in Castleton. And they needed some guy, and he wanted me to leave with him, my boss, to come be the financial guy at this new hospital. And I said I'd do it. I'm a trusting individual. He told me to show up to work the first day at the main hospital at 16th and Ritter. Well, I'd never been to the east side of Indianapolis. I didn't know where 16th and Ritter was. I called him the night before. I said, "Hey, how do you get to this place?" So he picked me up, drove me down there, and for the next 4 months I worked off of a tabletop in a hallway. But I got involved in healthcare. I'm 24 years old. I'm hoping they don't know that I don't know anything. But at this point in time, I'm now in charge of all the finances for this new hospital. And so that's where I started. And I did that for a while, and I bounced around a number of other positions until a few years ago when there was a change in the leader that we have for the organization was going to retire, and they asked me if I would be interested in applying for that job. And I applied for the job, I took it. And I today feel like I'm the luckiest person around, because here's some guy who literally is still an accountant by training. My wife still can't believe I can't even do our taxes, much less somebody else's. But I have the responsibility every day to try to coordinate physicians, and nurses, and therapists, and social workers, and admissions people, and dietary, and housekeeping, and all these other things to provide care. And to provide care wherever a patient needs care. And so I see myself as a coach of sorts to try to say, here's a team that we've got to coalesce, and this team has to have all these different talents. And to coalesce that team to make sure that when it's all said and done, we have a common purpose, and that common purpose is to provide a patient with the best possible care outcome possible, and to coordinate that care, and that's what we do. A little bit about the Community Health Network. We have actually 9 hospitals, if you count specialty hospitals, all in central Indiana. We're locally owned. We're a community, we're a not-for-profit 501c3, which means the small c community owns it. It's not, there's no investors, there's no real owners. So it's a not-for-profit hospital. And we have campuses. We have campuses in Castleton and on the east side and on the south side, on the west side where Dr. Williams is the president. And we have a campus in Anderson and we have a campus in Kokomo. So those are our 6 campuses, and then in addition to that, we have specialty hospitals. We have a heart hospital that's a specialty hospital, a behavioral care psychiatric hospital as well, and we have a rehab hospital. So those are our hospitals. Now on top of that, we've got multiple ambulatory clinics, urgent care facilities, physician offices, therapy locations, imaging locations, all kinds of other healthcare. So there's about 300 places in central Indiana that would have the name Community Health Network on them. And our mission is real simple. It's to enhance the health and well-being of the community we serve. And our community basically is greater central Indiana. And so each year, we just finished 2013. So in 2013, we had over 2 million encounters of people who received some care at our network. Over 2 million, which is staggering when you think about it. I mean, literally every single day, I'm rounding up just a slight bit, every single day about 10,000 patients hit one of our doors. And if you think about the fact that that patient has another person with them, basically a small town of people every day come to us for health care. As you get back to Marian and what you're doing here, in whether it's nursing or physician, or to be a physician, the need is overwhelming. Overwhelming. We started about 4 years ago. One of the primary initiatives that I provided the organization said that anybody, regardless of ability to pay, ought to be able to access health care for any reason within our system within 48 hours. 48 hours. The national average is 19 days. We did a quick check to say, how long does it take now? At that point in time, back 4 years ago, now 2010, 19% of the time did we achieve that standard. So 19% of the time when somebody was trying to get in for an appointment, did we see them in 48 hours. Today, as of the end of 2013, we have achieved that 83% of the time. And our goal is to get that to 24 hours. And the whole purpose is we're trying to match people. We're trying to identify what consumers want, and we can do that. But to me, the most striking thing is that no matter how much we've done to increase the ability to get in to see a physician, a nurse practitioner, a physical therapist, a radiation procedure, whatever that is, no matter how much more we've added to do that and how much we've shortened the time, we still can't meet the need. Our demands continue to go like this. We provided more care in 2013, any way you slice it and dice it, than we ever have in the history of our organization. And yet we know we need more. If you look at the east, anybody from the east side of Indianapolis? East side? Okay, so east side. So if you have east side, we've got our main hospital on the east side of Indianapolis at 16th and Ritter. In the past 3 years, we've added an ambulatory facility at 21st and Post, an ambulatory facility at East Washington and 465, and in there are urgent care facilities and therapies and physician offices, et cetera. We've added another 12 physician locations. We've expanded our residency program. We've added a Jane Pauley Family Health, federally qualified health center. We've expanded that federally qualified health center to 6 other sites. Okay, all that's happened on the east side in the past 3 years, and we still have just patients coming all the every day looking for access to care. And on top of that, and on top of all that, the volumes in our emergency room are like this. Now you would think by providing all these other places for somebody to be seen, we would not have the continual emergency room volumes we do. We see about 200 patients a day in the emergency room. So my point is that the pent-up demand for care is out there. When things happen like the Affordable Care Act, that's now in place, that gives people better access to healthcare coverage, or we're going through a debate. Matter of fact, I was supposed to speak here, Zach, like 6 weeks ago or something like that, and I rarely, I mean, it killed me to call and say I can't do it. I rarely have something. There's no such thing as an administrative emergency. We don't have emergency rooms for administrators. So, but we're in the process of trying to negotiate a deal to expand Medicaid with the governor in the governor's office, which is a good thing to get more people covered. And so they called the meeting date, and it was whenever this was supposed to be, and so I needed to be there. There's many people you still say yes, sir. I'm hoping somebody called me. So we're trying to make sure people have all this coverage, that they have access to health care. Like I know I grew up with health care. My kids have health care, and it's really called health care. And health care being things like getting prevention, having have a pediatrician, and with your pediatrician, you're having all your wellness checks and your baby checkups and all those things. One other thing I forgot to mention, we now are the health care providers for several school districts. Warren is one of them. Warren Central, Lawrence Central, Franklin Central. We do some things at Pike, Noblesville, Shelbyville, Franklin, Whiteland, Beech Grove. So it's kind of around that eastern ring. Several years ago, when the school funding got changed in the state, they changed the way in which they give schools money to provide education to kids. And then a lot of it got changed of how they get their funding. One of the things that was at risk was the school nurses. And so who's going to identify what meds people have? Who's going to try to make sure that people are getting vaccinations or getting flu shots or whatever it is, all the various things they're doing. And a lot of school systems were looking to cut out those nurses. We took a risk and stepped forward and said, we'll employ your nurses. So we took the burden of their nurses, put them on our payroll, so they actually work for community. And then we turn around and provide it back. But we coordinate with our physicians and nurses and nurse practitioners to say, what are we going to do? And how do you identify chronic illnesses? And how do you try to make sure that you identify those people that have issues and try to get them in some sort of a routine in care? Last year, in our just school clinics, these clinics that we run, we did 100,000 visits inside of schools for school kids. 100,000, which is fascinating. Now, if you ask my children or my children's children, my grandchildren, who their doctor is, who their pediatrician is, who their family physician is, they can all tell you. In the schools that we're in, less than half of those kids have a doctor, have a family physician. I have no idea. So some things that we take for granted. So what do you do about that? You get back to okay, this is a social issue. This is something outside of healthcare. It's an educational issue, a social issue. I mean, the child who goes to school and who is hungry, and the child that goes to school and is not healthy, is a child that's very likely not to learn. I was told that another reason why we put these clinics in these schools is that when my kids get sick and go home from school, somebody's going to be there with them and make sure that whatever needs to be taken care of is taken care of. That's not always common. And that each time a child leaves school and goes home, their chances of dropping out of school go like this. And by the fourth time, the rate of dropout has gone up exponentially. So what do? You've got to figure out how to partner. And so that's why we put clinics in schools. And then we've tried to engage our dietitians and our physicians and our nurse practitioners to say, what do you do for nutrition in school? What do you do for fitness and wellness and exercise and all these other things? What can you do to, in fact, try to help people be well? So it gets back to the insurance and well care versus sick care, which is just, you know, I got some problem. See me when I'm sick versus how do you make me help? How do you help make me healthy? I want to pause for a second and questions that you have, things I've talked about so far? No? You guys are awful nice. I've gotten involved here locally with an organization. It's now called Jump In. It started as something called Live Healthy Indy. And what this is, post the Super Bowl, you know, Indianapolis came together, business community, community leaders to, oh, thank you so much. Community leaders to rally money and volunteers and support for us to hold the Super Bowl a few years ago. And we're trying to get that again. We'll find out next month whether we're still in the running. When that was all over, we said, wouldn't it be cool if we could rally together for something else? And about being healthy. If you look at our ratings, Central Indiana or the state have been told that they're not very good. You know, of the 50 states, Marian County or Indiana, however you slice it back, said it's somewhere between 44th and 47th in the country on overall wellness. That's not the right word. Wellness or health. So, you know, it's easy to look at that and say, well, you know, our weather's bad. Oh, well, you know, other places have it easier. Oh, it's just not the things we do around here. There's just not fitness trails. There's not all these things. But you probably realize those are just excuses. Because one of the top 5 in any way you slice and dice is Minneapolis, Minnesota. So it can't be about weather. And then Chicago ranks higher than us, which is kind of hard to believe. And then you start going through all the various other places. Well, we've spent the last couple of years with the help of a lot of community leaders and also some assistance from the United Way and some consultants we hired to try to say, what can we do to change the overall healthiness of our population? And what it's come back down to is the fact that we need to make sure that we get adolescents by the age of 10 into wellness, fitness, nutrition, understanding as a way of life. And to do that in cooperation with the schools and the government organizations, because if we do that, we can change a curve. If you look at the obesity rates, just the overall rate of obesity, I mean, it's on a path like this of what's happened in the last decade. So we've come together and we said we're going to work as a Central Indiana community, and we're going to do everything we can to work in partnership with schools to try to address childhood obesity and not only try to change a generation going forward, but we're also going to try to change a family. Because there is evidence that says, you know, if Johnny is at 10 and starts doing all these other things, he does have the ability to influence other people in his family. But the rate of being sedentary, the foods that are being consumed, the lack of nutrition available in some places, those are some of the things we're looking at. So where does all this fit in? You know, you are looking to be healthcare providers. And when you think of what's happening, people, and I'm standing here, I'm not giving a political opinion at all. The whole people say, am I for or against the Affordable Care Act or Obamacare, whatever you want to call it? My answer is real simple. I have a job to run a healthcare system. This is the law. My job is to understand and implement the law. That's all there is. So this isn't about politics. This is about taking care of people. And the law has all kinds of focuses on wellness. That crazy thing called wellness. That health care should be about health. And so therefore, how do you incorporate the things that you do? How do you make it such that people do have access to information, do know what things they need to work on, do have the ability to make modifications in their life? Well, one of the things that we've invested heavily is electronic records. I mean, you're in a digital medical school. How cool? How cool? When Dr. Evans showed me this the first time, I thought, if I thought I could get in, I'd go back to school, but I couldn't handle the rejection right now. But it's just so special to understand that having the world at your fingertips, you can get this information. But why is it? Why is it I can take a credit card out of my wallet, I can stick it in 1,000,000 slots, and they can tell me virtually everything I've been doing for the last 24 hours. But to have that type of information on a medical record, we just haven't done. So the government's done some other good things as well. They told us that you will be digital. You either digitalize your records, and if you do that over this period of time, and you do it right, we'll offset some of the dollars. And if you don't do it, and you don't do it right, we're going to start taking payments away from you. I don't know how much you know about the government and insurance, or what Medicare, Medicaid, things you know, don't know? No? Okay, Medicare is basically a federal program for people that are over 65 or disabled. But most of it's people over 65. And Medicaid would be for the impoverished or the needy, and those are largely in the past been moms and babies. I mean, there's some exceptions, but it's largely moms and babies. Those two programs, this year, we will collect $2 billion in receipts for services we provide. Of those $2 billion, almost $1.5 billion will come from Medicare and Medicaid. Huge. So when you think about that, you think about the fact that who we're providing care to, we're providing care largely to the population. And it's not that we don't have, the working people, but if you look at the demographics of this country, the country's aging at a very rapid clip. And so therefore, the number of people being insured by the government are going up like this. At the same time, the government's expanding coverage. So to me, I see those as opportunities. Those are opportunities for us to say, okay, how do you do this better? And so one of the things that we've invested into, somewhere in the tune of $130 million the last 3 years into a digitalized computer record. And what it means is that, like right now, I can pull out my phone, log on to my chart, and on my chart, I've got my latest labs. I know what meds I'm on. I know if I have an upcoming doctor's appointment. I know that, and any of my doctors that see me, that information transmits. If I were to have an accident going home and I can go to the emergency room, that information they can call up. That's good stuff. And that's what you're getting that firsthand in all that you're doing. You're from a world that we're trying to make healthcare catch up with. So now we've got all these hundreds of sites all connected. And prior to being here, I was at a meeting downtown. We've got an organization in the city called the the state called the Indiana Health Information Exchange. It's called IHIE. And what that is, that's community and St. Vincent's and St. Francis and IU Health and Eskenazi Health formed this organization about a dozen years ago that says all this information we should be able to exchange with one another. We're one of the few places in the country that shares information across its competitors. That's a good thing. Yes, thank you for a question.
So you're saying that you could, log on to whatever the program is and look at all of your labs and everything. Is that something that every patient's able to do?
They are.
Okay, so then I know this is kind of like a pessimistic way of looking at it, but I'm just kind of curious about. So what if someone keeps themselves logged on and then someone else looks at it? Would that be, would that be a problem for community, or would that be a problem for just them?
Well, I'll give you a couple different answers. Okay, first answer is there are password protected and all that stuff, so you need to be on there. It will automatically time you out at some point in time. That's not to say that somebody couldn't take your smartphone or something like that. And I'll get back to that. But the other thing is, then there is a way to authorize for other members of my family. So based on age, especially with or without consent, we have that information as well. So at least you have some ability to get all this information. Your point on the privacy piece, there's all these HIPAA HIPAA regulations and rules that we've got to comply with. At the same time, what I see is good about it, in the old world, these were all on paper forms. We really never knew who looked at it, right? I mean, somebody pull a file cabinet, they pull whatever they want, check whatever they want, and close them. What we know now, especially if there's unauthorized looks, we know who looks at every chart every time, and we have auditors that are constantly going through and saying, were they authorized? I'm really sorry to say that I'm sure other organizations as well, every year we educate people on those HIPAA laws. We educate people, and you can only do this under these circumstances. We educate them and say, and if you do it and you're just snooping, it's an automatic termination. And the temptation, some people cannot handle that temptation. And so unfortunately, we do have that occur and have to deal with it.
Yeah, I think that's great. Now that I didn't think about it, like I'm not tech savvy enough to realize he probably does show a timeline with any user that looks at it, so it's just a dead giveaway. So I guess it is probably a better security system, especially since I'm sure family members are calling in and saying, I need to look at my husband's labs, and then people are saying, I can't release that to you until you talk to the doctor. So it seems like it's a less efficient way.
And that's even better than former husband's lab.
Yeah.
So there's a lot of things that happen. This is where I get off on all these tangents. One of the other biggest issues we have in healthcare these days is healthcare identity fraud, where somebody, say, doesn't have good health insurance, and they come in presenting themselves as somebody else. And so our people, when they admit, go through a set of screens to try to make sure that they're challenging people to make sure that they're talking to the right person. Because I'm not saying this happens 50% of the time, but it's a high enough percentage that it's a concern. And the problem is now, somebody's coming in as somebody they're not, and they're doing that to get access to insurance. But the problem is, they're really getting care. And that care may not be safe based upon what their issues are. So that's another one. And the third one, I'd say this a big one, is just whole medication. You're just having, what meds are you on? You can imagine the story. I take the green one in the mornings, and I take the red one on Tuesdays, and I take, all this, what idea are they, what are the dosages, etc. And so at least try to get to a common source of what meds or prescriptions somebody's on, so that those people providing treatment really know what's going on within their bodies.
I just have one more thing to ask.
That's
Sorry.
okay.
So a lot of us that are Christian med students here, we've had most conversations about, people who are, addicted to, painkillers or something, and you said that you guys share those files with the hospitals. So would that be something that they could say, someone comes into the ED and they're like, I need pain medicine?
Yes.
And then they're like, wait a second, we looked on this, and you've been prescribed 2 times, and we should have doctors, so they keep record of that?
That's a fabulous question, because that's where you get back to the value of the technology, what we can do. Hospitals, emergency rooms, urgent care facilities, pharmacies, retail pharmacies, all these things now can share this information like that, so that we can try to address that situation. Because people get pretty crafty on how they're pursuing that addiction, and hopefully at the same time you provide help. So this whole idea of everything being electronic and in some sort of a central system has its problems, no doubt about it. It slows us down. It's been through quite a transformation, especially with physicians. I'm not going to look at Paul or David when I say this, but you can basically, there's a line where you draw, where under that line, it's about the physicians, or it's about time we should be doing this, and over that line is that, so you're asking me to either practice medicine or run a computer. And so we've had a lot of counseling and coaching and try to get people through this. And when it's all said and done, it's, in my opinion, we have more information, so we make better decisions, and we also have less chance of duplication. I know I've had situations in the past where somebody says, did you have this done or that done, and you have it done. And then you're someplace else a few days later, they don't have the result. And so give it done again. Two other points on this topic that I think are pretty cool is, one, we now have the ability to push labs out safely within 48 hours of that lab being done. So we've had pushback from a lot of our physicians and nurse practitioners saying, wait a minute, they're going to get it before I get it. And so we've been going through a process to say, okay, we're going to meet in the middle somewhere in here to give the physician enough time to look at it if that's what they choose to do. But for instance, but we believe that the patient has the right to have that information. Now, I had a history of I had a physical a few weeks ago, and so I had my labs done, and so I get it. I don't know what all this stuff means, but it says, here's the lab, here's the range. I know if I'm in the range or not, based upon what it's saying. So therefore, when I go to speak to my physician, I can have an educated conversation about, you know, I can ask questions, if I got a problem, how do I address the problem? There's a far better engagement than somebody just showing me something the first time, and I don't know what to do with it. I was talking with a person in my position at another organization out east, and they said that with the exception of behavioral care, so mental illness, with the exception of mental illness, 100% of all notes made by whomever are available to the patient family. 100%. And I said, okay, so tell me why. And they said, it's for patient safety. And I said, tell me more. They said, what they found is that if a physician's in a room with a patient and there's a conversation going on, and especially if there's other people in the room, there might be other dialogue, they're hearing different things. So they're having the ability to check the result of that conversation. And they said it's amazing how many times they find errors, and they're not intentional errors, but they're errors. And that